Good afternoon. Welcome to the weekly HSE briefing. And could I ask the speakers to introduce themselves from the left, please?
Damien McCallion, HSE National Lead for the Vaccination Programme.
Colin Henry, Chief Clinical Officer, HSE.
Niamh O'Byrne, National Lead for Testing and Contact Tracing.
Paul Reid, CEO.
And I'm Mark Brennock, National Director of Communications. And could I welcome our Irish Sign Language interpreters, Michael and Susan. This briefing is being broadcast live on the RTE News channel and on the HSE Twitter feed. And could I ask Paul Reid to give his weekly update?
Thanks, Mark, and good afternoon, everybody. First of all, I want to say the pace, the progress and the uptake of the vaccination programme here in Ireland is no doubt a great exemplar all across Europe and probably in many parts of the world in terms of uptake in particular. Aside from the health protections that it's offering to many people at the moment, the programme has also given us all a glide path to some level of normality where we can start to rebuild society and the economy. The benefits of protections that it's given to everybody, I think, particularly people in Ireland, is beyond many people's expectations to date. We've developed in the HSE an operating model that's proven to be very agile. We've now changed the model about at least 32 times based on various different policy decisions or directions, and it's proven to be effective in each one. We're now seeing people aged 16 to 17 years of age registering for vaccinations, which is really positive. And the vaccination for children from 12 to 15 years of age will start very soon. We now have 71% of the adult population already fully vaccinated and 86% of the adult population partially vaccinated. Huge credit is really due to everybody involved in the vaccination programme, either directly or indirectly. And it's impossible to name the kind of roles, organisations or people who was involved in the vaccination programme, but inevitably it ranges from all those people who are carrying out the vaccinations, vaccinators themselves, GPs, pharmacies, but also those people, cleaners, car park attendants, volunteers, who've given a lot of time and support to vaccination centres in particular, but also agencies like the Defence Forces and Garda Síochána. And I certainly have never been more proud in my career than I am of everybody who's involved in this programme. They continue to play a great role overall. And in the day of sporting metaverse, it is truly a Team Ireland process and success. And we continue to race towards the final furlong of the rollout. But as we always say here each week, the job isn't done yet. As we continue to vaccinate young people, teenagers and children, we equally have to protect them. As we all know, they are now the new vulnerable in terms of this virus. We all know more and more young people who are testing positive of late and how quickly that spreads to their siblings, their friends, their teammates, their sporting friends. We're continuing to see a strong demand for our testing activity overall, and my colleague, Ms. Niamh O'Byrne, will bring you through some of that shortly. But ultimately, the positivity rate for testing and for walk-ins and self-referrals is at 11.7% and rising, some sites at 21% positivity. As Niamh set out, the age groups 15 to 24 having the highest referral volumes and the highest positivity overall at 14% positivity. And from a HSE perspective, because of the risk that this poses, we again want to stress we're not out of the woods with Delta just yet. And as vaccinated adults, there's a real strong obligation on all of us to demonstrate the right public behaviours to support younger people in the final stretch as we try and aim to get them all vaccinated and protect them too. Just specifically related to hospitalisations, today we're at 160 COVID positive patients in hospital, 26 in ICU. The number of confirmed patients with COVID in hospitals is up 60% compared to when we were talking to you this time last week. Over the past 7 days, there's been 181 confirmed new cases into hospital. The number of confirmed cases in ICU is up 18% compared to this time last week, thankfully off a lower base. So while the figures aren't alarming in themselves, they are a cause of continued concern for us as they continue to rise and rise at a time when we have significant pressures and stress on our hospitals. And just to compare that figure of 160 today, just over a month ago, there was just 39 people, just over 4 weeks ago in hospital compared to that 160 today. So hospital attendances, as you've seen over the last few days, are up significantly, and significant amount of pressures on a range of our hospitals across the country. There are a number of factors driving this as we get the feedback from our hospital system overall. Firstly, it's a significant proportion of delayed presentations, people who didn't present for themselves for illness during COVID. And a significant proportion of those delayed presentations are from older people needing, in most cases, actually high acute care. That does have significant pressures on a hospital system because on admissions, more older people, generally about 50%, can be admitted by comparison with about 25% of general population. And that they do have a much longer length of stay, and that's what we're seeing of late. Older and more frail people who have delayed care coming through. Also seeing a factor in some of our hospitals of there's obviously a lot more people having their holidays and staycations in Ireland, and in many cases engaging in activities and sporting activities that they might not normally engage in. So we're seeing more injuries coming as people are on leave and engaged in various activities. And also in many cases, complete families bringing older parents on holidays with them as well. So then do attend to hospitals outside of their normal regions. Obviously increasing sporting activity and injuries that we are seeing coming forward. And so again, I do make the call to everybody that many of our hospitals are under very significant pressure. If you can, please do seek a GP consultation or a pharmacy consultation, or indeed attend to one of our minor injury units. Our emergency departments are there, they are open, they're there for emergency care. But as you've seen over the last few days, some of them are under significant pressure and are having to delay elective care. So I'll make that call to everybody again. Just a brief reference to an ongoing process that we're engaged in, which is to capture further data, particularly to try to understand impact of Delta versus previous variants of COVID on hospitalizations, etc. We're continuously capturing some of that data to try provide us with some further insights as we move through Delta. And we will present much of that data as we have it finalised. But just some initial assessments that we can kind of share with you. But again, off a relatively low base and a snapshot. But on early analysis, the majority of cases of COVID in hospital have been admitted because of COVID. A smaller number may have contracted COVID in hospital via an outbreak, for example, what we had a week or so ago in Mayo. These patients may not themselves be as sick as other COVID patients. There's another smaller number of patients who may have attended for other reasons and on being tested are positive for COVID. In most hospitals, COVID patients are indeed quite sick and need high acute medical care. That can involve medical attention on the ward as people are hospitalised, or indeed, as we set out previously, receiving advanced respiratory support, not in an ICU, but outside of an ICU and needing high acuity care, and indeed in ICUs themselves. So regardless if a patient is admitted with COVID or is identified with COVID in hospital, they'll ultimately be treated and monitored for COVID, along with their identified illness or presented illness. So while many people, some people in hospital are very sick with the disease, there may be some who are not as sick, but all being treated. I do want to make just a couple of points on this. Every COVID patient has a disproportionate effect on the health system. And I don't mean that on the patient themselves, but the fact that we have COVID positive patients has a very disproportionate effect. All must be isolated in accordance with guidance and infection prevention control measures to reduce the spread of the infection in hospital settings. Every positive COVID patient in hospital does put additional strain on our health system in terms of trying to identify isolation rooms, secure isolation rooms, staff precautions that we have to take, stepping back and sometimes unplanned or elective care, and many other impacts. Isolation capacity, as you all know, is limited in many of our hospitals with more ageing infrastructure. So it does have an impact on the entire hospital. So each COVID-19 patient brings a risk of spread of disease and indeed needs treatment for it. I do also want to just send a very clear and strong message so there's no ambiguity about dangers of contracting COVID or being hospitalised with COVID, because there's a lot of misinformation out there about this. Nobody should be of any view that being hospitalised with COVID is not serious. Talk to any of our frontline staff, talk to any of our healthcare workers who are treating people on a daily basis, and they'll explain the seriousness of treating people with COVID. In fact, I recall again, Bernie Waterhouse, Nurse Bernie Waterhouse, clinical nurse manager from St James's up the road here, who we presented at a conference some time ago, clearly set out the severe impacts patients with COVID were experiencing. And there is, in saying all of that, I do also want to state you are stronger, much stronger protected from being hospitalised once you are fully vaccinated. So please do take up this offer. Vast majority of the people and age groups we have gone through have done so, and we will continue to make that offer available to all of the Irish population. Just on our vaccination programme, now over 5.72 million vaccines administered up to yesterday evening. Almost 3.25 million people have now received their first dose or single dose for the vaccine, 86% of the adults population. Over 2.7 million of adults have received their second dose or their single dose, 71%. On the 12 to 15-year-olds, we can answer some further questions with my colleague Damien McCallion, but we are finalising plans for the vaccination of these young age groups. We do need to make significant enhancements to our IT system to facilitate the consent process and record the consent process, which is being worked through and just being assessed at the moment. We do expect over the next 2 weeks to be commencing that programme, but we will give some further details throughout next week. The uptake will remain strong, which I normally fill you on each week. The uptake, again, just coming back to how we are an exemplar. For those 80 years plus, 99%, 70 to 79s, 98%, 60 to 69s, 95%, 50 to 59s, 93%, and 40 to 49s, 88%. Last week, our plan was to administer about approximately 300,000 vaccines. The total outcome was 326,000 vaccines administered. This week, the week we're in, we do plan or are on track to administer up to 300,000 vaccines again. And next week, as we start to work through smaller numbers of population, we plan to administer about 250,000 again, based on supply levels as well. On the 16 and 17-year-olds, just to mention, as of yesterday evening, 47,600 of 16 and 17-year-olds have registered online for the vaccine. 24,770 of the 17-year-olds and 22,830 of the 16-year-olds. Just on the digital cert, I just want to make a few very brief comments on this. The HSE has provided the information for 97% of those who are fully vaccinated with the correct information to the cross-government initiative for the issuing of the digital certificate. There's 2.7 million people, as I've just mentioned, fully vaccinated, of which just over 2.6 million vaccine digital certificates have been provided. The HSE isn't responsible or doesn't lead on the distribution of certificates or indeed on the call centre. But just to mention that there are a few areas that have been identified to date which have been impacted on the distribution of the certificate. First of all, emails bouncing back from a mailbox, either being full or being spammed. Incorrect postal addresses given at the time, incorrect contact details provided. In some cases, the vaccinators at the location of AM being given, maybe a GP or pharmacy, hasn't submitted the full details just yet. So there's a range of issues just to flag up there. Finally, just closing messages from myself to summarise. The vaccination programme in Ireland is having a very significant and massive benefits beyond our expectations. And we are setting a very high bar for many other countries in terms of our uptake. We are on the final furlong, as I described, in the race to get the adult population vaccinated, and we'll shortly commence the process for the 12 to 15-year-olds based on the required consents. And we can definitely be certain that the vaccination programme has reduced illness, reduced hospitalisations, and has reduced ICU admissions, and it has saved lives. I'm certainly, again, very proud of everybody involved in this programme to date and the momentum that we have behind the vaccination programme. But equally in closing, I do want to just say also, as adults who have been vaccinated, we do all have an obligation to be ambassadors for the younger people who have not been vaccinated to date and are vulnerable. So they too will look at our adherence to public health measures and take a lead from us. And I'd urge everybody to do just that and support that. And finally, we can't drop our guard at this very great point that we're at. It's far too early for now. So I'm going to pass across my colleague, Ms. Niamh O'Byrne.
Good afternoon, everybody. So just some key messages from the test and tracing service. So across testing and tracing, we are continuing to see very strong demand across the testing sites. But while it's high, it is steadying. And over the last week, we've seen a slight decline in the demand at around 3%. So at the moment, this demand is staying in or around in the community around 15,000 tests per day between Monday and Friday. Overall, though, there are some days that exceed 24,000 in overall swabs taken. The metrics are doing quite well. The swab to lab result within 24 hours is now the median. The overall end-to-end process is within 2 days, and 94% of people can get a COVID test within less than 24 hours. It remains very important to still continue to come forward for testing and to engage with our contact tracing teams when they make contact with you. We are still operating a number of pop-up sites across the country. There are a few in Dublin between Blanchardstown, Tala and Sandyford, also in Donegal, Athlone, Laois and Cork. And over the next few days, we will open an additional site in Dundalk and also in Westport and Mayo. Across these sites, as Paul mentioned, the positivity does continue to rise. So while the volume of testing isn't increasing, the positivity does increase. And now between walk-ins and self-referrals, which are the vast majority of our community testing, the positivity level stands at 11.7. There are some sites still in excess of 21% positivity, and there are a number of sites that are particularly busy. They continue to be Donegal, Louth, Meath and Monaghan. The younger people, 15 to 24, are the highest referral volumes. They take up the majority of the testing appointments, and they are also the highest positivity level at 14%. Last week also was a busy week in contact tracing. The workload was up 22% on the prior week, and over 24,000 close contacts were contacted by us and 9,000 cases. When we look at close contacts, household does remain the largest portion of close contacts at 45%. But this week, for one of the first times, they're not the highest in terms of positivity level. Transport is the highest positivity. That means non-flight related transport. That's cars, buses, trains. And after that, it comes to household again at 19.7% and social, which is increased to be expected as we have continued to open up. Over 29% though of close contacts are now fully vaccinated. And this is a positive trend. This has continued to move up due to the success of the vaccination programme. So this number was 19% last week. So what this is showing us is that we're continuing to get more and more protection for people. And if you are a close contact who's fully vaccinated and you do not have symptoms, you don't come into the testing system. So that's continuing to impact the number of close contacts coming forward for testing as the weeks go on. We continue to focus on antigen testing in terms of looking at 2 studies. So we started the 3rd level study in Dublin, Cavan, Mayo and Galway. This week we started going into some 3rd level institutions and doing antigen testing in staff and students. That is going to commence for the next cover of the next 4 weeks. We're also starting in those counties plus Wicklow for early years, which will start after the bank holiday weekend with testing of staff in early years sectors. and that will we will look at the results of those studies week on week and at the end of the 4-week cycle, and expect to roll that into further sites if all goes well. These are not antigen validation studies; they are operational studies to see how it works, and a large portion of the feedback will be how did it go, what were the results, and how did people find using the tests, and ultimately was it helpful to the local public health departments in the control of the disease in those sectors. We are also continuing to look at other technologies around antigen testing, better deployment of them throughout the community, which makes it easier for people to access them. And we are also looking at how we track results from antigen through a more digital format of forms and apps. And again, that'll come out over the coming weeks. As a final message, we do continue to urge people to not attend social gatherings or sports training or place of work if they have symptoms of COVID-19. Stay at home, get yourself a test, and await the results of your test. I'd now like to hand over to Dr. Colm Henry.
Thank you, Niamh. I just want to go through some of the current disease indicators and trends to pick up on the messages you've heard so far. So, looking at our 14-day incidence, it's now at 338 per 100,000. It peaked on the 17th of January at 1492. The 5-day moving average, 1264. And that's some sense of it plateauing over the past few days. It's an early indicator. It's too early to say if that will remain the case, but some sense of it plateauing. And that 5-day moving average peaked at well over 6,000 on the 10th of January. Our hospital admissions are a bit higher than the figure stated, as our ITU admissions, showing an increase of 60% on last week and 18% for ITU on last week. Excuse me. So new cases of COVID have risen in the month of July from a weekly average of 485 to, as I said, 1270. And you can see in that graph at the top, that sense of plateauing. Last week, we were worried that we would be reaching, it was possible we would be reaching 2,000 cases per day this week. It doesn't appear likely now. On the blue graph, you see the rise in hospital instances from a low of 42 patients with COVID at the beginning of the month to where we are now at 150. And likewise, in ITU, a steady, slight increase. And you'll all know by now of that lag time between the rise in cases and the rise in harm. And I'll talk briefly about that weakening of the link between cases and harm and what our greater understanding of that is in one or two slides. So looking at the EU, this is a little historic, it comes from the ECDC. We're up there in terms of 14-day instances. We're actually higher than the figure stated here. And again, this underlines the remarkable volatility of 14-day instances where countries who are well performing can switch to be poorly performing in the blink of an eye. In our own country then, we know that there's a huge county differential with Donegal at a 14-day instance, 972, Louth and Laois also quite high. Looking at a 7-day over 14-day instance, in other words, looking back over the past 14 days, what's the trend? And for overall, for the country, the 7-day over 14-day is 52%, showing a slight excess in the past 7 days, but a sense also that the breaks are beginning to take hold, and maybe too early to say. And in 17 of the 26 counties, we see a 7-day over 14-day of greater than 50%. Again, while it's still rising, there's some sense of a slowing, which is a hopeful sign. Looking at the age groups then, you've heard about this, the great majority in those either unvaccinated or partly vaccinated population, and only a tiny proportion, 2.8%, in that highly vulnerable age group of 65 or older. Looking at children, 11% in those less than 13 years of age in the last 2 weeks. So again, you've heard before the past 24 hours and at this press conference, big age groups, 19 to 24, 13 to 18, and 25 to 34. That's where the action is at the moment. Outbreaks, that flood wall of defence is holding tight in nursing homes and community hospitals. Just think back to January when we saw 7 or 8 outbreaks per day, each leading to multiple cases, to severe illness and death. In acute hospitals, we have seen the flood wall breached a little, 5 outbreaks, 14 cases, but as of yet, none of the severe disruption and severe threat to health that we saw in times past, particularly in January and February. First dose vaccinations in the EU, we continue to compare very favourably with other countries. Iceland remains at the top, and we're in 5th place. And you've heard of the percentage of age groups that have been vaccinated. We have reached remarkable levels that are surely the envy of other European countries. We thought at the beginning it was perhaps a function of fear, largely among older people who had everything to fear from the virus and much less to fear from the vaccine. That's holding tight in a remarkable way among middle-aged groups, where we see uptake of 94% for dose 1, 89% 40-49. That's not taking into account of those who registered. The registration for 30-39s, for example, is now at 86%. So that's it's not just the 82% who received dose 1, 86% have registered. Likewise for 2029, although 64% have received dose 1, 74% have registered interest. And these are remarkably high levels and higher, as I said, the envy of other European countries. And it's a remarkable tribute not just to people's interpretation and their own analysis of the risk of the virus, but that sense of social solidarity that has been served us so well since March of 2020. Looking at ITU, this ITU admissions from March 25th to July 26th, which somewhat predates the arrival of Delta. So it's not a consistent pattern here, but the majority, 78% of total ITU admissions of 136 occurred in the unvaccinated population. 16%, that's 22, in those partially vaccinated, and a small proportion, 6%, in those fully vaccinated. And of those partially vaccinated, a great majority had an underlying condition. So this is not a surprise. The vaccine doesn't give 100% protection, but just imagine what this would look like with a Delta surge in the absence of a vaccine, and with that population who are vulnerable underlying conditions who would be exposed. We'd be looking at much higher numbers in ITU, pressures on our healthcare system, and of course severe illness and unfortunately death. An analysis of the wave, I mentioned this last week, shows wave 1 back in February, March 2020, that mean age, 60 years of age. Wave 2, a smaller wave with only 170 ITU admissions. That mean age was 67. Wave 3, by far our most severe wave, almost 1,000 people admitted to ITU. The mean age is 62. But so far, based on the analysis to date, albeit a smaller number, you can see that mean age has fallen to 52, reflecting the course of the illness and the flow towards unvaccinated or partly vaccinated people. The variant, it is now Delta is by far the dominant variant, well over 2,000 cases proven on full genomic sequencing, but we hardly need the sequencing to tell us now that the great majority of cases are due to Delta. Analysis of Public Health England, they've had over 200,000 Delta cases, and of those, 1 in 8 were fully vaccinated. And of the total ED presentations that resulted in hospital admission, 1 in 5 were fully vaccinated. And of those that died, albeit a relatively small number relative to the whole picture, which I'll show in a second, just over 1/3 were fully vaccinated. This study I referred to before, a study of 45,000 healthcare workers in the UK, of whom 95% are vaccinated, shows that flood wall of defence holding tight among healthcare workers in the UK. But nevertheless, when the figures rose, as they did in recent times, to as much as 50 or 60,000 a day, we saw breakthrough infections, albeit at a relatively small number, but nevertheless, that figure never rising in terms of harm, never rising remotely to the level it was before vaccination was widespread among healthcare workers in the UK. And the latest evidence shows that vaccine effectiveness after dose 1 against Delta, 80% reduction in hospitalisation. Again, after dose 2, 96% reduction in hospitalisation. And that proves all of that contention to date, that it protects against the most serious harm. And even when it comes to protecting against illness due to COVID, symptomatic illness, which of course is a great majority of cases that don't require hospitalisation, still 80% after dose 2 are effective against Delta, 35% against dose 1. We did know there was a weakening against less severe illness after dose 1, but dose 2 gives a really strong protection against symptomatic illness, regardless whether you need hospitalisation or not. But dose 2s, look at that, 96% almost against hospitalisation. That is a remarkable high level of protection for any vaccine. So what's happening in the UK? We've seen, I just want to touch on this briefly, cases not just plateauing, but a sense of falling from that peak of July 17, 54,000 cases to now below 25,000. Something that people are still beginning to interpret. What does this mean? It's too early to say. What happened that caused it to peak to 54,000? There's a few ideas behind that. Hospitalizations, remember the lag time. It takes a while for the oil tanker to turn after the cases fall. So they're still beginning to rise, albeit that link between hospitalisation case is greatly weakened, and likewise with deaths, the 7-day average of deaths per million is levelling out. And this slide, if I could just show briefly, look at that second wave in January and February on the left-hand side. The red on the left is the cases per 100,000 as you go through days 1 to 50 of that surge. And you can see a rapidly increased number of cases. And on the right-hand side of that red graph, you can see the number of deaths correlating closely with the number of cases. What's happened more recently is, again, looking at this third surge, look at the grey on the left, on this side, increasing right through to day 50, the number of deaths, not quite broken, but a huge weakening of the link between cases and deaths. Demonstrating the highly protective effect of vaccine, not just at individual level, but at population level against the most severe illness. Why did the spike? One possible conjecture is the Euros. The blue line here are men with male cases. The purple line is female cases. And there was this differential between the two at critical times during the Euros, suggesting there may have been a differential that the congregation and the effect of coming together and the excitement and that resulted that we saw ourselves through World Cups and Euros may have had some part in contributing, and that gender divide has narrowed again and now beginning to fall. Briefly, Florida, just again, vaccine effect. Florida, big rise in cases. They eased the restrictions, perhaps too early as interpretation. In early May, when their cases were higher than New York State, which is the red line. New York, on the other hand, removed the restrictions in mid-June when cases were low. And you can see the difference in terms of new cases. The blue line in the upper graph shows a big jump in Florida versus New York, which is held tight. Likewise, Indonesia against the UK. The UK being the yellow line here, blue being Indonesia. But look at the death differential on the right-hand side being the UK and Indonesia. So cases mirror each other, but the deaths, big divergence. And the only really plausible explanation is a huge differential in vaccination population between the two countries. I'm sorry for the businesses slide. We're coming to the end now. Just wanted to explain. People are asking, why is it we're seeing people who are fully vaccinated in hospitals? Why is it we're seeing people in ITU who are fully vaccinated? And there is an explanation for this, which is, first of all, we know it's not 100% effective, but the more people are vaccinated, the higher their share of hospitalizations would be. It's quite a simple concept when you think about it, that as you vaccinate more and more people, and there are breakthrough infections, therefore you'll see more numbers in the vaccinated population. So on the left-hand side, for example, if you have 1 million people, 70% fully vaccinated, you'll see a total of making a number of assumptions of the protective effect of the vaccine and of the chances of getting hospitalised. You'll see 600 admitted to hospital, for example, under this assumption, for those who are not fully vaccinated, and 84 admitted to hospital who are fully vaccinated. On the right-hand side, here, where 92% are fully vaccinated, you see a greater proportion of those among the fully vaccinated population because they're a greater part of the population. But look at the total hospitalizations. On the left-hand side, where less of the population is vaccinated, you have a total of about 684 admissions to hospital. On the right-hand side, it's 270. So just because we see numbers in hospitals of fully vaccinated, and you might see them, it doesn't represent a failure of the vaccine program. It's because we're vaccinating more and more people, and out of that cohort of people, you'll see breakthrough infections, and you see greater numbers as you vaccinate a greater proportion of the population. Briefly, a NIAC recommendation of children and young people has been well aired over the past 24 hours. The benefits, they made this judgment purely on the benefits and risks of this age group. There's strong recommendation for those with underlying conditions to get the vaccine. And of course, we're making it available to all children of those ages, and based on consent and information provided to them to allow their parents to make a decision on their behalf. A summary then, final slide. The Delta variant is spreading worldwide. We know it's much more transmissible. Some trending towards a plateau, but with remaining uncertainty. The link between case and hospitalisation has been considerably weakened. But there is a high rate of hospitalisation and deaths in unvaccinated and partly vaccinated. And some countries reintroducing or introduced public health measures. And those who are fully vaccinated have a very high level of protection. I encourage anybody listening who's wavering or wondering is get vaccinated. There is no excuse for lack of opportunity. There are now walk-in vaccination opportunities. We will facilitate you any way we can. Gurmaigov.
Thank you very much, Colin. And now we take some questions. John.
Could we just clear up the issue about herd immunity? We heard at the HSE briefing last week, we were told that we needed about 90% now vaccination to achieve herd immunity because of the higher transmissibility of the Delta variant. When we put this to the Department of Health yesterday, quite bristled at the notion of herd immunity, saying that we haven't been able to suppress respiratory diseases. It might not be possible with the Delta variant and the vaccines we have to achieve herd immunity. So can I just ask, as you say, we're coming onto the final furlong, exactly what we're aiming for and what we mean by herd immunity?
The concept of herd immunity was raised last year by the WHO and others as something that we might aspire to. And at that time, if you remember last year, we were based on our knowledge of the virus's transmissibility, there was but based on limited information projections, there was an idea that we had to cover 60 or 70% of the population. I think there's a general awareness that herd immunity in the strictest sense of the term is very difficult to attain with a virus where you have changing variants, where you have increased transmissibility. The objective now of the great majority of countries is to vaccinate as many people as you can to reduce harm at individual level and to protect healthcare systems. Any commentary in herd immunity was made here, otherwise was just leading on from dialogue that began last year at WHO level and otherwise, that the levels of the population need to be covered, the critical proportion to stop transmission of the virus were predicted or projected to be at the order of 60, 70%, and now are predicted to be much higher based on the characteristics of the current variant, the Delta variant. Whether or not that's achievable, many people, including Anthony Fauci in the UK, would feel that it's no longer a realistic objective, and our primary objective is to vaccinate as many people as we can and confer protection to them and through them to the population at large.
Just add briefly to the second part of that question, what are we trying to do? Certainly from an HSE perspective, we're trying to do exactly what we've been doing to start it as we walk through vulnerable groups, first of all, and vaccinate them in sequence, and that has worked. As we walk down medically vulnerable, vaccinate them, healthcare workers. Then as we walk down through the ages, aiming to get the highest uptake possible that we can get. And that's what we're continuing with. It's worked all the way to the 40s, as we're now vaccinating 30s, 20s and 18s, 16s and 17s. We want to get the highest level of uptake that we can get in each age group. So that's exactly what we are aiming for to do and have been from the start. Protect vulnerable groups first and get the highest level of uptake in each age group after that.
Shauna Bowers with the Irish Examiner. I know you said you're kind of working on finalising plans to vaccinate 12 to 15-year-olds. Could you tell us anything more about what the current plan is or will be?
And that's so effectively the population is around 280,000 in that age group based on the CSO figures. So one is that we will primarily use the vaccination centres, but we're also going to work with GPs and pharmacies for a couple of reasons. One is geography. And two will also be, we recognise there may be some young children who may not find a vaccination centre appropriate, people perhaps with disability or autism and so on. And we want to make sure there's alternatives there for people. In terms of timing, what we're looking at, there's a number of key things. NIAC set out very clearly that we must make sure the appropriate information and consent is made available to parents, and we're working on both a communications campaign at a global level, but also making sure our National Immunisation Officer ensuring that the information is available to people at an individual level as well. So that's one piece. The second piece then is our system, our registration system is obviously adult focused up until now, and we're incorporating the consent elements into that. So over the next couple of weeks, we'll finalise a date, an exact date for when we launch that over the coming days. But we're talking round about over the next couple of weeks in terms of when that would formally commence.
Do you have any idea of roughly how many children in this age bracket will be vaccinated before the return to schools?
Well, I think that's what we'd call guesswork. We've been here before in lots of the different age groups. I mean, what we will do is we'll put the information out there. As Paul and Colin have said, the population have responded well to all of the vaccine age groups and cohorts that we've had to work through so far. We'll certainly be encouraging people to make an informed decision and to get vaccinated as quickly as possible. We'll also have to be pragmatic. We're in the holiday season and so on, so there's other factors that are at play. But we'll work to try and ensure that we give people as much access as we can, give people the information and try and encourage early take-up so that people are, as you say, vaccinated perhaps before they return to school with their first dose, which will give them a level of protection before the schools reopen.
As Damien has touched on, we're looking at the uptake will be a factor and the supply line will be a factor because there's obviously a lot of dose tools to complete in August as well. So it's just modelling all of that out as well, which Damien and his team are doing as well.
There appears to be slightly more scepticism about the vaccination of children than there has been adults. And when I say that, I mean referring to social media and things like that. So if you were talking to parents now, why would you advise them to get their children vaccinated? What are the benefits?
I think if you listen to Karina Butler and other experts, she and her colleagues in NIAC took a great deal of time over this, and they've kind of nuanced their advice accordingly. So they're strongly advising people who've underlying conditions, children of underlying conditions, strongly advising them and their parents to take the vaccine up to protect them against illness due to COVID, not just acute illness, but also potential longer-term illness. In terms of healthy, thankfully the great majority, 12 to 15-year-olds are healthy, the balance of advice would be to vaccinate because thankfully, although severe COVID illness is rare in children of this age group, it isn't absent. And we know that we've had admissions in this age group. We know that there are rare instances of multi-systems immune disorders and that can cause severe illness. And we know also what is unknown, I suppose, I should say what is unknown, other than known, is the impact of long COVID. And that's something that's an evolving knowledge. If you'd asked me 6 or 12 months ago about long COVID, I would have had little to say about it apart from the observational reports that were coming through to us from different hospitals. We have a greater sense of it now. And although it's commoner in older age, we do see quite a lot of it in younger people. As to how much of it we see in 13 to or 12 to 15-year-olds, it's too early to say. But the overall risks, benefits versus risks, based on the NIAC advice, which is purely focused on the benefits for children themselves, was for those with at-risk underlying conditions to strongly recommend taking the vaccine. Those who are healthy, the balance of benefits are in favour of taking the vaccine, but that people should be informed. They should read all the information that we will be supplying to them to allow them to make a properly informed consent about taking the vaccine.
Craig Hughes from the Irish Daily Mail. Paul, do you have any sense or any timeline of when the booster shot campaign will have to be rolled out again? I mean, will it be the same order as before, or will frontline healthcare workers who are perhaps at more risk be done first in this instance?
There's two parts to the question. I'll ask Damien just give a little bit more detail, but certainly in the NIAC recommendations, they did set out to commence the booster as part of the flu vaccination campaign and addressing vulnerable groups, probably most likely in a similar order as we went through the vaccination programme for COVID. Separate to that, we're looking ahead in terms of what that would all look like from an operational perspective. We certainly see community pharmacies and GPs playing a key role and looking at the role of vaccination centres beyond September. Obviously, we don't envisage needing the full suite of vaccination centres, but we still possibly see them roll. So that's a piece we're looking out separately based on the recent advice from NIAC, but it does set out a prioritisation for boosters. Damien, do you want to give any more?
Yeah, and I suppose the letter also leaves scope for further evidence to emerge around boosters, so it does identify some of the initial priority groups that we'd consider. And I suppose we have been working in the background on this because we could see that this was going to come along, Craig, that in some way, shape or form, potentially we would have to have a booster campaign. So, our National Immunisation Officer are well used to running through the flu vaccine, and we're working collaboratively now to look at how we would do that in a joined up way, I suppose, for both flu and COVID over the winter. So I suppose that we have the current letter. There is more scope clearly within that for other groups. It does set out the initial priority groups, very similar to those that we've dealt with in the COVID vaccine programme so far.
Sorry, would you envisage getting the 2 jabs on the same day? Is that what you mean by running it side by side?
We'll leave that to the clinicians to decide, I suppose, about how that will be dispatched. But look, we've just got that advice this week, so we're trying to work that through now and look at how we would join that up in terms of how you'd actually administer it, but also the mechanisms. As Paul said, GPs and pharmacies would be the prime vehicle for the booster campaign, but we'll look at what we might need to put alongside that to ensure that we get everyone vaccinated within whatever the time windows that are set by NIAC.
When this vaccine program started, we used to one of the advice was our advice was initially was to have it separate from other vaccine, but that doesn't prevail anymore. There's no reason we can't give the vaccine alongside at the same time as something like the flu vaccine.
Just finally for me, Paul, I know previously you had said that you had the powers to move people out of frontline duties if they had refused vaccination, to people in hospitals and things like that. Has there been any instances where someone in the HSE has had to be removed or moved to a different role because they've refused vaccination?
Well, specifically, it's not so much the powers, but health legislation does facilitate health risk assessment to be done on areas of a person isn't vaccinated. Local management can do risk assessments, and based on that risk assessment, if somebody isn't vaccinated and they judge that they can't carry out that frontline role, that's facilitated in the legislation. And there have been occasions where management teams have done that assessment and worked through if somebody needs to be moved to a new role or a different role. We've sent out, Colin Henry has sent out recently a circular and a notice out to the whole system to say that this is important, but he needs to look at it and make those assessments. So we support any local managers who have done that assessment and taken appropriate action.
Any figures on that? How many people have been moved because it's
a smaller number? Colin, I want to.
What we've done, Craig, is engage with all the line managers and CHOs and hospital groups and enable them to make the right decisions. But I think in terms of support, it's important for us to emphasise the first thing we want to do, of course, is vaccinate as many healthcare workers as possible. And so if there are healthcare workers for whatever reason haven't been vaccinated and for whom and are able to get the vaccine, there's no contraindication. We want to encourage them to get the vaccine. What we've done here in this action that you're referring to is simply enable our managers in both hospitals and the community that when they're dealing with frontline healthcare staff who are not vaccinated, in the context of a surge of Delta cases, to carry out a risk assessment, having ensured that all the other infection prevention and control measures are in place to protect patients and staff, and that if they're in place and the risk assessment determines the frontline healthcare worker needs to be redeployed, that enables them to do so. And that's an appropriate response in any pandemic that protects patients and protects staff.
Hey, Richard Chambers from Virgin Media News. Damien, I just note what you said there about the 12 to 15-year-olds. You said this would get underway in the next couple of weeks. The government earlier this week said that they'd hope to start this by the end of next week. Are you saying that's not feasible, that's not likely to happen then, or what's the story?
All I'm really saying, Richard, is the things that we need to do are largely around the information consent, both the public campaign and the individual piece that's been worked through. And the second piece, I think, which was even mentioned in the media this morning, is around the technology changes to the system, and that'll be the critical path. So we're working to get there as quickly as possible, as we always have, and we'll work that out over the next few days, what that actual deadline looks like. So, it's just going to be in around that sort of period. We're not going to get hung up on it, but effectively we want to get there as quickly as possible. But equally, we want to make sure we honour and respect the recommendations from NIAC in terms of all the elements that are there around it.
And just in terms, Colin, obviously, just from what you were saying there about early signs of plateauing in terms of hospital numbers as well as in new infections, there was a great deal of optimism expressed last night at the NEFIT briefing as well, that there might be scope to ease off restrictions in the next number of weeks. Are you from your own point of view? Do you think we're ahead of where you might have thought we would be? Are we doing better? Are you more optimistic, actually, should I say, than you would have been a week ago or 2 weeks ago?
Well, there's a phrase in Irish, Tarkil Cannyhagging, meaning we bought sense dearly. So while there are positive trends such as plateauing, it's quite early, and we want to see that if it is a true plateau, we want to see further evidence of that. And unfortunately, the hard answers only time will tell. Of course, it's grounds for some optimism, but the hard truth is that it will require a greater degree of time before that trend becomes more definitive, and we're able to say not only have the cases plateaued out, but the harm associated with the cases have not resulted in a significant rise in hospitalizations, have not resulted in a significant rise in people needing ITU, and have not resulted in large numbers of people being sick who are vaccinated. So it is a trend, but bear in mind we're still seeing an increased number of cases. As I said in the presentation, the 7-day over 14-day is still over 50% in 17 counties. There is a sense maybe of breaks beginning to take hold, but we won't know for another couple of weeks.
A couple of points. I think the public should have great grounds for optimism based on what's happening with the vaccination programme. It's really proven great benefits, and as we've demonstrated here today, reducing illness, hospitalisation. Secondly, the cases appear to have plateaued for a few days. We would like to see another week of that before we confirm it as a trend. Thirdly, our hospitalisations haven't plateaued. Our hospitalisations are actually growing, 60% up in last week. So that, from HSE perspective, is a cause of concern for us, particularly with the pressures that's on our hospital system at the moment. So, we see great grounds for optimism, but we would always caution that right now we don't want people to drop their guard. We want people to keep their guard up. Let's get the rest of the younger people vaccinated, and we'll be all in a much stronger position.
Yeah, just one more for me then, just in terms of ICU admissions or people who have been treated in ICU over the last number of weeks or months. Do we have an age profile or a breakdown of underlying conditions in those? Because obviously, if the vast majority of those are people who are unvaccinated, does that mean that they're coming from a younger cohort, or is this actually something which is being proven to come from people just choosing not to be vaccinated?
I think I could give a breakdown of that. Sorry.
26 that we had, a smaller number, 3 of them vast majority were over the age of 50. Smaller number 3 were younger age groups, so vast majority were over 50. And that's just a snapshot. And I would always say to everybody, you can't take a judgment from 25 or 26. Thankfully, we're coming from a lower base, but that's something we'll be watching. But you are correct, and Colm's slide demonstrated it. Being vaccinated is a much stronger protection versus not being vaccinated from ICU. Sorry, Colm.
Hi, Paul O'Donoghue from Newstalk. Just first of all, in terms of the progress that we're making, it was only last week that the Taoiseach was saying that we're expecting up to 4,000 cases per day at the peak of this wave. Is that prediction out the window now? What are we expecting at the peak now?
So when you look across the different models, we got a revision on models yesterday. There are still some models in it that do have high numbers of cases. So in the most optimistic of models, which is the track we're currently on, the peak cases would be somewhere around 2,500 to 3,000. And it's a slow rise, slightly different shape of a curve. But there still are other models which have dependencies on other assumptions to do with social mixing and transmission. And they still do have very high levels of cases into over 10,000 cases. So it does depend on which way we track. And at the moment, we are seeing a steadying in both the demand and in the case numbers. But it's difficult to see quite now where that's going to go.
And for both the optimistic and pessimistic views, are the peaks at roughly the same time, and when are they likely to be?
The peaks come later into August, and we start to see a plateauing across September and a decline then further into the back end of September, October.
Just as well on maternity restrictions, I think it was today that the Taoiseach was saying that there shouldn't be any maternity restrictions anymore in hospitals. Can you give information as to how many hospitals or maternity units still have any restrictions on partners visiting, which ones those are as well?
I might go through the, as we eased restrictions as we came out of that surge 2 in February. In mid-May, we followed up with the 19 maternity units to see who were compliant with the first 4 of measures of easing, and there were the maternity visits should facilitate a minimum 30-minute visit day. That was postnatally. This is back when things were higher. That the partner should be there during labour on the labour ward. The partner should be facilitated at the anomaly scan, and partners should be facilitated at visits to neonatal units. So our most recent assessment of those, that all 19 units are fully compliant with this. And we further revised the guidelines on the 23rd of June. And that included easing the restrictions for early pregnancy assessment units, for routine visits where a woman was considered to have a higher risk pregnancy, and for emergency presentations in late gestation. And we've analysed, obviously we followed up and found that in those 3 areas, the great majority of hospitals are fully compliant and are partly compliant in some isolated cases, particularly with high-risk pregnancies. There were some difficulties and differences between the units in terms of infrastructure, in terms of how they respond, how quickly they responded, but the general trend is towards full compliance.
So on those ones, so it's around routine visits and emergency presentations. So how many hospitals are not fully compliant?
So for early pregnancy assessment units, based on our last survey, that's 18 were fully compliant, 1 was not. For routine visits where a woman was considered of a higher risk pregnancy, 12 were fully compliant, 7 were partially. For emergency presentations and late gestation, 15 were fully compliant and 4 were partially.
For those that aren't compliant, why would that still be the case?
Working with them, because obviously we've asked them to have full compliance. So we'll be, again, it's a circular survey, and engage with our NWHIP and acute hospital colleagues to ensure we get full compliance, as we did with those first 4 criteria with the first revision of guidelines.
Sorry, do you know when you would expect full compliance in all hospitals?
Well, I'm certainly hoping the coming week, we've engaged with them, expecting full compliance, yes.
More question. Paul, I think you were saying around the number of COVID cases in hospital, that the majority of cases in hospital are currently being treated for COVID. Can you, I suppose, be a bit more specific there? Like, say if there are 100 COVID cases in hospital, how many of those people are specifically being treated for COVID?
Yeah, just the first thing to say, if there's 100 people in the hospital identified as COVID, at some stage they will all be assessed and treated with COVID. People identified are admitted for COVID. Again, a snapshot of what we're seeing over the last week or so, about 70%. Yeah. And then a smaller proportion, which were, of the remaining 30%, a smaller proportion which might be healthcare associated infections or an outbreak in a hospital, such as Mayo, example last week, and may not be as sick, and others who came in for other illnesses and then identified as COVID. But they too may get very sick in hospital with COVID. So just to make the point again, once you're in hospital with COVID, you'll be treated with COVID, and we have to put all the protections in around the hospital based on that as well.
Thanks very much. Arthur Beasley from the Irish Times. Damien, a question in relation to vaccinations and the time lag between the first and the second. There seems to be some suggestion out there on social media, suggesting that the gap between the first and second vaccination has come back to 18 days in some cases. Is that so, and has there been a policy change?
No, and Colin might want to comment on this as well, but effectively the second dose is that sort of 21 to 28 days window, 21 to 42 day window in relation to the vaccines, and that's the window that we operate within. So certainly some people may be within that 21 days, but there's certainly not at 18 days. So there's no policy shift. So what we have done is where we were actually bringing people back, say, on Pfizer at 4 weeks, we're now bringing them back at 3 weeks in some cases as well, which is, again, within the use of the product. That's a decision through our National Immunisation Office. So there's nothing down to 18 days. So policy is 3 to 4 weeks, always has been. Some people will be within that window and some will be longer. And again, the dose is still valid if you're over the 4 weeks. That was also a concern of some people at some stage, perhaps, that they were over the 4 weeks getting the dose after 5 weeks or so on. That isn't an issue in relation to the efficacy of the vaccine at that point either. I don't know, Colin, if you want to add anything to that.
Further question in relation to the hotline for people and the certificates. How is that going at the moment?
Yeah, so I think as Paul said earlier, I suppose from a HSE's perspective, our role was to try and get the 2.6 million records over. Paul described some of the issues that are there around that in relation to why people may not have got it from a HSE perspective. It can be email addresses are incorrect, it can be home addresses are incorrect. I'll give you an example. Say, I think we've in the region of 8,000 postal letters that have come back. We have a whole team who will go through those one by one to get those out to people. The model was based on the line, obviously then been available for people who have an urgent need. That has clearly been compounded in the last 10 days in terms of the volume is in excess of what's there. And in fairness to the people running the helpline, they're trying to expand the resources that are there to deal with that, but also to get the message out there in relation to travel, just to contact if you've got an urgent case, because what's happening is people who are genuinely urgent then perhaps may not get through. And also then in relation to the food and hospitality sector, the decision was made in relation to the guidance to the sector that people can use their vaccine card to try and take the pressure off the line, where some people were probably worried they might not get in for a meal or a drink or whatever around that. So that flexibility was left within those guidelines that went out to the sector to try and take the pressure off, so that for travel purposes, which is what the certificate was originally designed for, that would improve the chance alongside the resources that are gone in. The other thing I'd say is there's some technology changes, I believe, that are going to go into place as well, where people will be able to request basic changes. So apart from maybe contact details being incorrect, which might be the source for why people don't get a certificate, the other factor for people is their concern that their name is different to their passport. And understandably, at the time they were vaccinated, no one knew that the digital cert was going to come along in that way, and hence they're ringing up and concerned about travel and so on. So there'll be a mechanism where some of those changes can be requested and validated electronically, which will also help the service to improve going forward. So we're still supporting it in relation from a HSE perspective in terms of ongoing provision of the information, correcting anything that needs to get corrected coming back. But that work has been done through the Digital Contact Centre, and we're supporting the department in that regard as well.
When might that mechanism be introduced? If you're at home with a cert on your phone that's different to your passport, when might you be expected to be available?
My understanding is it's imminent. We're not directly providing that from a HSE perspective, but I know there's a team working on that, and the hope would be that over the next sort of 7 to 10 days, I think is the approximate window. But as I say, we're not directly involved in the provision of that. We are involved in the overall process, and we're working with all the other parts of government, I suppose, to try and make sure this works.
And is it your advice to people who are looking at travel, who have concerns around their vaccine passport, that they should wait until soon before they're due to travel for fear of squeezing out people who are literally on deadline, so to speak? In other words, that some people are moving too early to go to the phone line.
I think the general advice is, if you have imminent travel, then that's what the helpline is there for. Clearly, it has had issues, so that's the general advice from government, and obviously the HSE would support that. We want to ensure that people. We'll make sure the information is there, and if it isn't there, we put a process in place to track it back. Even if it means going back to a GP or a pharmacist or to our own hospitals or our own centres to try and make sure we gather the information. So we have a separate team stood up that deal with those complex queries, if you like, as well, to support the overall process. But obviously, we're not in the travel business, but we would, again, encourage people to follow that advice just to try and improve as the service does improve. And there are more resources going in, and as I said, there's additional solutions. This week, I think a solution went in for the recovery certificate where people can request that online, and that has helped. I don't have the numbers, but I know there's been significant usage of that as well.
Richard.
Sorry, Damien, it's just to clarify what you were saying to Arthur about people being offered second doses after 17 days. Are you saying people aren't being offered doses after 18 days, 17 days, or?
So 21 days is the recommended window that we're working to from there, that 3 weeks outwards. That's in line with the manufacturer's guidance around that. That's what we're working to. There may be people, say, getting the offer for an appointment, but their dosage date should still be around the 21 days and onwards.
There's a whole stack of people online who've been contacting the HSE on Twitter who say their second doses for the 17th and the 18th, and the HSE is responding saying anything after 17 is A-OK.
21 is ours, and we can respond to that. If there's queries, we can pick those up, Richard, certainly. But our change in policy, if you like, that we put in around the National Immunisation Office is just to provide that flexibility. And it's just an operational change, I suppose, in terms of use. It's within the guidance. But again, to be clear, what we're saying is that your second dose is offered within that window. It can be at any point 21 days out, 28 days, and even beyond that, and that doesn't change or impact on the efficacy of the vaccine.
Okay, but HSE are telling people online that 18 days, getting their second dose after 18 days is good. Are you saying that's against what you're generally guiding?
No, well, I'm not sure what you're referring to. Obviously, I haven't seen the Twitter piece, but we can pick that up separately in relation to any individual queries around that. I can't comment on individual cases. But in terms of our own vaccines, we're running from 21 days onwards. It doesn't mean if someone's getting that earlier, there's any impact in relation to the vaccine itself. I just want to be clear on that in case people are concerned that there's something wrong with their second dose. That isn't the case. But in general terms, we're offering from 21 days outwards is what we're working to at the moment.
There is a prescribed time period, a gap, which falls in the licence. People are getting it sooner. Obviously, it's something that has to be tightened up on, but they won't be any less covered as a consequence. Just if anybody, it has happened, someone, I've no doubt it has, if it's appearing the way you said, people are concerned, their coverage is not diminished as a consequence.
Challenge than we might have had a few weeks ago, where people were, challenged to go beyond their periods. So, but that is something, Richard, we look at.
I think I misheard there. Just about the COVID cases in hospital, 70% would have been admitted because of COVID. And
about 70%.
Right. And then of the 30%, did you say some of them would have been healthcare?
No, a small number may have become infected in hospital. For example, we had an outbreak in Mayo, a healthcare associated infection. Sorry, John. Yeah.
Broadly speaking, when you look at the entirety of cases in hospital in any country, the first is people who are sick, who are admitted because they have complications of COVID or discovered to have COVID at the point of admission in the emergency department. Secondly, are people who acquire COVID in hospital. So they're admitted with something else and they acquire COVID, and that protracts their stay. And thirdly, are people picked up under surveillance. And that is to say, for example, if there's an outbreak and there's an index case found, and based on the risk assessment, they test everyone in the ward or the pod or whatever it is, and people are test positive who don't have any symptoms but are deemed to be positive. So, roughly, as you heard, whatever it is, up to 70% are primarily sick with COVID, and that's the reason they're in hospital. But what it cannot be lost, because I know there's a lot of focus on this, is the impact of all the cases, all those three categories, is enormous in terms of healthcare. It's hugely disruptive because all have to be treated as if they can transmit COVID onwards to patients who are vulnerable, patients who are post-operative, patients who are unvaccinated, people who are immunosuppressed, people on chemotherapy, and so on. So all must be treated as if they have the power to transmit COVID onwards to somebody who may become severely ill with it. Hence the highly disruptive effect, not just the people who are sick with COVID, but those who have no symptoms.
Just add one point to that, because I am really conscious over the last week or so, a number of messages are getting mixed up. Certainly, as Colm said, this has a disruptive effect, disproportionate disruptive effect, COVID patients overall do, not the patients themselves, but the fact they're COVID positive patients. But the second point I want to emphasise again today, in case there's any impression out there of getting sick with COVID or ending up in hospital COVID, it's not a big thing. It is. People who are sick in hospital with COVID are in many cases needing high acute care, ventilation supported, or in some cases in ICU. So I just want to kill that impression, that seems to be floating around of misinformation. Well, it's not really that bad if you get COVID or you end up in hospital. Talk to any of our frontline staff, they'll tell you what it's like. Talk to patients who've been in hospital COVID, they'll tell you the symptoms.
Just meant to confirm, Damien, on the booster campaign, do we know how it'll be worked out, who will get it? I think you're kind of saying immunity lasts for about 8 to 10 months. So is it the case that if you got your first dose, say in April, you'll get a booster in December, or if you got your second dose in April. So how will that be worked out?
So, look, I mean, we've only got the NIAC letter, and that's just setting out the categories for consideration initially, and that's really just to assist us in planning through the winter. So none of that detail is specified so far, and that'll be a balance, I suppose, of clinical advice and operational considerations in terms of what timeframe that might be operated in. You know, so there will be people obviously who started earlier who may warrant it, and there's also differences in timing between second doses. So we look at all that as part of the booster plan.
Just briefly as well, it was mentioned at last week's briefing that there's been a sharp increase in eating disorder referrals during COVID, and I just got further stats from the HSE afterwards showing that referrals to the 3 specialist units this year in the first 6 months of the year are already higher than last year. So, you know, looks like nearly a doubling. So what's the HSE doing to address this issue?
Just specifically on it, the details that we did put out there last week, we are specifically seeing it in some of the CAMS units as well, particularly children and adults, adolescents, mental health services. A number of recruitment initiatives that we have this year in our CAMS teams, proven challenging but significant recruitment that we have funded for to resource further. So that's primarily our focus. Not easy to get qualified, skilled people available, but that is part of our strategy.
Anybody else? No? Well, thank you very much. We'll see you next week.